Hello everyone, I'm Joe Featherall, and this presentation is going to be regarding intra-articular antibiotic therapy for prosthetic joint infection. And this presentation was produced for completion of the requirements of a sub-internship for Stanford University Orthopedic Surgery Department, particularly the rotation at the Veterans Affairs Hospital in Palo Alto. So let's jump right in. A little bit about the epidemiology of prosthetic joint infection, or also sometimes referred to as peri-prosthetic joint infection, or PJI. It is a devastating complication of total joint arthroplasty. And although it's rare, an incidence of from 2 to 2.4%, some estimations are a bit lower than this, but it is truly a huge burden to both the patient and the health system when it happens. As you'll see through the course of this presentation, it often requires multiple debridement procedures, removal of implants, and then multiple procedures before the reimplantation of prostheses, if that does occur at all. And because of this tremendous burden, it has a huge economic cost, and it's projected to be about 1.62 billion annually by the year 2020. So if we look at the pathophysiology, this gives us some understanding of why it's such a difficult problem. So it's believed to be caused by seeding of bacteria into the peri-prosthetic region, either through direct inoculation through the surgical wound site, perhaps intraoperatively, possibly postoperatively, in the situation where you have a wound infection that can track deep into the prosthesis space, and then delayed or late onset PJI is thought to be from a hematogenous spread from an infection location somewhere else in the body. Once the microbes are on the implant surface, because there's no blood flow and it is a synthetic surface, you'll end up with a biofilm forming on the implant surfaces. This biofilm is a broader issue in healthcare. It occurs on indwelling catheters, in central lines, as well as on Foley catheters, and prosthetic devices such as heart valves, in the case of heart valve or prosthetic heart valve endocarditis. There's a process that the microbe goes through. So normally we can see here this little E. coli that's mobilized by its flagella. It comes down and adheres to the surface, be that polymethyl methacrylate, cement, or the metal components, or the plastic components of the implant. It uses adhesin fimbriae to start to form a sheet in which they adhere to each other. And then eventually, as the biofilm matures, you get this polysaccharide thick capsule with other bacterial proteins that protect the bacteria themselves. The metabolic rate of the bacteria slows down in this state, and eventually they sort of cause this budding off of bacteria that can then go back into the joint space or into the circulation. And the issue with these biofilms is that they become strongly antibiotic resistant. So for example, in some studies, E. coli biofilm requires about 500 times the minimal inhibitory concentration of ampicillin to achieve log-fold killing. In another study with Staph aureus, they used about 10-fold vancomycin dosing to achieve a log-3 reduction. Some of the mechanisms of this is thought to be the polysaccharide matrix that slows the diffusion of antibiotic to the bacteria. As I mentioned before, the bacterial growth is slowed, and therefore uptake of antibacterial substances is also slowed. And in this close proximity within the biofilm, there's opportunity for rapid DNA exchange of resistance plasmids. Because of all of this, systemic antibiotic therapy does not typically provide high enough concentrations of antibiotic to successfully eradicate the infection. Given this situation, is why antibiotics in the joint itself has become a mainstay of therapy. And the main method of doing this has evolved to be the use of cement, or polymethyl methacrylate cement, either in the form of beads or in the form of a spacer that is placed into the joint after the removal of the implant. And this spacer then elutes antibiotics into the deep tissues in the joint space. So Hsee in 2004 published data on this, demonstrating that about 94% of hips treated with beads and 96% of hips treated with an antibiotic spacer in a small case series demonstrated infection control. They also found that the spacer leads to better interim function and easier reimplantation due to the preserved lengths of the soft tissues. However, as we progressed forward with using this treatment of explant and implantation of the antibiotic-loaded cement, we seem to have found that it doesn't necessarily work as well as was initially reported. This is some more recent data from the Rothman Institute, where Gomez et al. Presented a history of 504 PJIs that were treated with the standard explant and antibiotic cement loading, and they followed them for a mean of 56 months. Only 83% of these patients actually underwent a reimplantation. So that means that they went on to be treated with multiple spacers, or they had a retained spacer that they lived with for the rest of their life, or they died of infection-related or other causes. Of the group that did undergo reimplantation, only 81% of those were successful in 1 year. So if we combined all this data together, we're looking at something like a 70% success rate. And this is, we have to keep in mind that about 104 patients were lost to follow-up. So there are limitations with this. The best available data is retrospective. It's smaller case series because the incidence of this is so low. But at best, about 70% successful treatment with minimum 1 year follow-up. Also, something to keep in mind is that Nelson and his group took a number of explanted spacers. They sonicated them to remove any biofilm or bacteria that might be on those spacers at the time, and found that about 50% of them still had biofilm on them upon removal. So even though we're placing antibiotics in the cement and using that to treat the infection, we do have biofilms that are growing on the antibiotic-eluting spacers themselves. And part of this is maybe due to the characteristics of antibiotic elution from these spacers. So if we look at this study by Kelm et al., we can see that by day 4, we have less than 20 micrograms per milliliter concentration in the solution in the joint or surrounding the spacer. And if we look at some of the models that we talked about before, using the minimal inhibitory concentration for the biofilm, many of them are greater than the 20 grams per microliter. So even just a few days after the placement of the spacer, we are likely below the minimum required dose for eradication of a biofilm. So that's one of the main limitations of the PMMA with antibiotic. Because of this, a number of groups have been trying to augment the the dosing of antibiotics or the concentration of antibiotics within the joint. So Risitano et al. Described a technique in 2018 using molded calcium sulfate antibiotic impregnated beads. As you can see here, they're molded in the operating room and then they're placed in the joint. Some of the advantages of this technology is that there are no surfaces to support biofilm growth because the beads are completely resorbed. Because they're completely resorbed, this also obviates the need for surgical removal. However, clinical data is yet forthcoming for this technique. There was another technique that was developed quite a while ago. Davenport reported on this in 1991 when he produced a case series of treating acute PJI directly postoperatively with an implantable antibiotic pump. With this pump, they're able to target a specific dosing of amikacin. And they had 17 of 20 patients treated with this method infection-free at 30 months. And this allowed for prosthetic retention in 17 of these 20 cases. Some of the failures that occurred were 2 Staph aureus infections that occurred 2 years post-initial surgery. So these may have been more chronic infections. And they had 1 immunocompromised patient that remained on suppressive therapy. This technique has sort of been modified and used again more recently in combination with the explant and aggressive debridement that we're familiar with. And this has been successful in both primary chronic infection and also reinfection, which is notoriously extremely difficult to treat, that being that the patient has already been treated with an explant and spacer placement and has undergone a secondary prosthesis after that. So as Whiteside described it, this technique uses a very aggressive debridement, often using a bivalve osteotomy to remove the cement mantle that extends into the shaft of the femur, meticulous antibiotic irrigation, regowning, redraping, and oftentimes using muscle flaps and tibial tubercle osteotomy to increase the amount of exposure. So it's a very aggressive debridement protocol that they're using. And then they used a Hickman catheter for direct administration of intra-articular antibiotics and direct or single-stage placement of cementless implants. And 17 out of 18 knees in this series were without infection at 2 years or greater, the way they have 1 failure that resulted in amputation. So this is some of the most difficult cases, and this technique of achieving very high intra-articular concentration of antibiotics over 4 to 6 weeks seems to be successfully eradicating the biofilm. And if we think back to the previous slide where the spacer is only providing this antibiotic for at a high enough dose for likely less than a week, Whiteside is using this for many weeks at a very high antibiotic dosing. This similar technique was then repeated by Antony et al. In a slightly larger cohort, N of 57, again in this very difficult population of reinfection. And they had an 89% clinical success rate at 11 months. So corroborating Whiteside's initial evidence. Moving to a summary and recapping on some of the issues. PJI is an absolutely devastating complication in total arthroplasty, and the burden is increasing due to the increasing comorbidities of patients and the popularity of these procedures. Intra-articular antibiotics are a key component because higher concentrations of antibiotics are feasible with less systemic toxicity. Currently, the most widely used treatment is explant, antibiotic spacer, and then later revision or a 2-stage procedure. The limitations of this technique include that there is limited quality data given some limitations with the nature of this problem. low antibiotic dosing and intra-articular decay curve when using the spacer itself, and then biofilm formation directly on the methacrylate cement. Emerging techniques include augmenting antibiotic dosing using calcium sulfate antibiotic impregnated beads, and then also the intra-articular catheter seems to be a promising technique. Other issues are that the definitions of PJI are unclear, whether it's acute, chronic, late, whether there is a component of osteomyelitis, or whether it's merely just a prosthetic septic arthritis where the infection is confined to the joint space itself. There are variability in the results, and the procedures used are very complicated. They're long procedures. There are a number of different techniques, and the debridement itself can be either aggressive or less aggressive. And so there's going to be a lot of variability in how the decolonization / debridement is done. And then also another big issue, as we've mentioned a number of times, is that the standard therapy or the methacrylate cement spacer does actually support biofilm formation and maybe a potential failure modality. So thank you for your time. And I hope that in the coming years, we're able to increase the amount of research in this area and really help develop higher success rates for patients who really have a difficult problem in the setting of total arthroplasty. So thank you.